Hey everyone, welcome to this explainer. Today, we're stepping into the high-stakes, hyper-precise world of clinical diagnostics. We're going to permanently untangle a web of concepts that, honestly, routinely trip up even the brightest future physicians and the general public alike. We're talking about sexual orientation and gender identity, specifically focusing on the rigorous medical and legal frameworks that actually define them.
So let's just dive right in with a question. Would you fall for this really common misconception? Picture this. You're reading a clinical vignette that describes a patient's gender identity. Does that automatically tell you their sexual orientation? Well, no. Conflating identity with orientation is literally the single most frequently misunderstood concept in clinical settings. Our goal today is to make absolutely sure you never make this mistake, whether you're prepping for a medical board exam or just trying to navigate human identity with a bit more precision.
To master this whole puzzle, here's our roadmap. We'll hit the 4 foundational constructs, trace the evolution of the terminology, distinguish dysphoria from biology, break down the landmark legal frameworks, and wrap up with medical management. Let's get to it.
All right, kicking things off with Section 1, the 4-construct framework. Let's cleanly separate the 4 foundational pillars of human identity.
First up is biological or chromosomal sex. Now, what's interesting here is just how concrete this is. We're talking strictly about physical, genetic, and anatomical traits. You know, the chromosomes you have, your gonads, hormone levels, your genitalia. In the medical world, this is classified as male, female, or, in cases of differences in sex development, an intersex variation. It's purely physical.
Moving on to our second pillar, gender identity. This is an entirely separate axis from biological sex. It's all about someone's internal, deeply held psychological sense of self. Basically, it's who you are in your head, male, female, a blend of both, or neither, and this is regardless of the sex you were assigned at birth. If that internal identity perfectly aligns with your assigned biological sex, you're cisgender. If it doesn't align, the term is transgender.
Our third pillar is gender expression. If identity is internal, well, expression is external. It's simply how you present your gender to the outside world, right? This comes through in your choice of dress, your behavior, your mannerisms. And a crucial point here, this outward expression might align with the societal expectations usually tied to your assigned sex, but it totally might not.
And the fourth pillar is sexual orientation. The big takeaway here is that this is strictly about the direction of your emotional, romantic, or sexual attraction to others. Heterosexual, homosexual, bisexual, asexual. It is completely independent of those first 3 constructs. Honestly, the easiest way to look at it is to think of biology, identity, expression, and orientation as 4 completely separate lanes on a highway.
Okay, let's put this knowledge to the test, exactly the way a medical diagnostic scenario would. Picture a 28-year-old, assigned male at birth, who identifies as a woman and is romantically attracted to women. Which 2 distinct constructs are we looking at here?
This is a brilliant illustration of a classic pitfall. The answers? Gender identity, because she is a transgender woman, and sexual orientation, because she's attracted to women. The scenario hands us identity and orientation as 2 completely separate, independent facts. You absolutely cannot assume one dictates the other. Conflating the 2, that is the ultimate rookie mistake.
Now that our foundation is rock solid, let's look at Section 2, the evolution of medical diagnostics. Understanding how these terms changed over time is key to spotting outdated myths.
Tracing the history here shows a very clear, ongoing trajectory of depathologization. Back in 1973, homosexuality was entirely removed from the DSM as a mental disorder, a huge milestone. Then, looking at gender identity, the older DSM-4 used to use the term gender identity disorder, but modern manuals have evolved, thankfully. The DSM-5 replaced that with gender dysphoria, and the global ICD-11 introduced gender incongruence.
Now here is a massive misconception that trips people up with these modern manuals. If you compare them side by side, the DSM-5 shifted its diagnostic focus completely away from the identity itself and strictly onto the distress, specifically the clinically significant distress of dysphoria lasting 6 months or more. The identity isn't the pathology. Meanwhile, the ICD-11 took it a massive step further. It completely pulled gender incongruence out of the mental disorders chapter and put it under conditions related to sexual health.
When you're evaluating DSM-5 gender dysphoria, remember it requires that marked incongruence to last at least 6 months, along with clinically significant distress. But watch out for this specific trap examiners love. Some people try to group gender dysphoria with paraphilias, atypical sexual interests. No way. Gender dysphoria is definitively not a paraphilic disorder. They are entirely separate diagnostic categories.
Which brings us right to Section 3, Identity versus Biological Development.
Here's where we see how another major clinical distinction builds on our framework. Differences of sex development, or DSDs, involve atypical physical sex development. We're talking about conditions with chromosomal, gonadal, or anatomical variations, like congenital adrenal hyperplasia or androgen insensitivity syndrome.
The common error here, confusing the biological with the psychological. For instance, if a scenario presents a newborn baby with ambiguous genitalia, this is fundamentally a biological DSD issue. It needs a physical workup, a karyotype for chromosomes, hormonal assays, imaging. It is absolutely not a gender identity question. I mean, you can't exactly ask a newborn their psychological gender identity, right? Conflating a physical DSD with psychological identity is a classic high-yield clinical error.
Let's pivot over to Section 4, Landmark Indian Legal Frameworks, and see how this all translates into the eyes of the law.
This perfectly divides the two most commonly confused Indian Supreme Court judgments. In 2014, the Nalsa versus Union of India case legally recognized gender identity, officially affirming a third gender and transgender rights. Then, 4 years later, Navtej Singh Johar versus Union of India decriminalized consensual same-sex conduct by reading down Section 377. So, the key takeaway? Nalsa is strictly about gender identity. Navtej Singh Johar is strictly about sexual orientation. Definitely don't mix those up.
And building directly on the foundation of that 2014 Nalsa judgment, we got the Transgender Persons Act of 2019. This was incredibly important legislation that codified statutory protections all across India, ensuring anti-discrimination, the legal right to a self-perceived gender identity, and guaranteed access to healthcare and education.
Finally, let's wrap up with Section 5, Evidence-Based Medical Management.
So how do physicians actually treat gender dysphoria today? Well, management in modern medical practice is highly individualized and super multidisciplinary. It's guided by international standards of care and generally follows a sequence based on the patient's specific needs, their age, and of course, informed consent. This process usually starts with psychological support and counseling. It can progress to gender-affirming hormone therapy and may eventually include gender-affirming surgery.
And this leads to our final, absolute must-know ethical standard. When a professional provides mental health support, the goal is purely to address the distress of the dysphoria. It is never to change the patient's identity. Any attempt to change a person's orientation or identity, which is often called conversion therapy, has absolutely zero medical evidence base. Worse, it's associated with severe psychological harm and is definitively rejected as completely unethical by major psychiatric and medical bodies worldwide.
We've covered a lot of ground today, moving from that concrete four-construct framework to some pretty complex medical guidelines and landmark legal rulings. But I want to leave you with a final thought to mull over. If modern medicine and landmark laws so clearly and intentionally separate biological sex, internal identity, external expression, and sexual orientation, how might mastering this level of clinical precision change the way you view everyday societal debates? When you strip away all the confusion, the clarity is actually quite powerful. Thanks so much for joining me on this explainer. Keep learning, and I'll catch you next time.